Hello and welcome to the Society of Critical Care Medicine's Critical Care podcast. I'm your host, Dr. Ludwig Lin. Today I will be speaking with Gintas Krichunas, MPH, MA, on the article The Association Between Endotracheal Tube Size and Aspiration During FEES in Acute Respiratory Failure Survivors, recently published in Critical Care Medicine. To access this full article, visit ccmjournal.org. Gintas is a research assistant professor of otolaryngology at Boston University School of Medicine and Boston Medical Center in Massachusetts. His research focuses on clinical aspects of dysphagia and outcomes. Gintas, welcome to the podcast. Thank you for being here. And let's just do logistics first. Do you have any disclosures to report?
Thank you very much for having me on today. It's a pleasure to be here, and I have no disclosures to report.
Okay, so let's get started. I personally was so happy to be able to discuss this topic because a lot of focus, thankfully now in critical care, is about helping critically ill patients recover and thinking about all the various sequelae and complications during that period. And tracheal injury, dysphagia are definitely part of that. So this paper definitely inserts a good thinking point for all of us. So not to assume that any of us know everything about this topic, I would like to get you to just kind of go over what made you guys look into this, what is the technology that you use to examine this, and then we can talk about the meaning behind the data.
Sure. So as you mentioned, the sequela of long-term intubation, often has focused on kind of the mortality, morbidity pieces, but a really important aspect of it really is dysphagia and aspiration for a couple of reasons. Obviously, you don't want patients who recently extubated to aspirate because obviously of aspiration pneumonia risk, among others. But there's this fine balance between allowing patients to eat and drink and be provided medications in a timely way, and also ensuring that they're safe. Um, so so that's kind of the global context of kind of aspiration, dysphagia, and extubation with ARF patient population. Um, but an interesting piece to this, I think, is can we predict, or in this case, can you find ways to modify that risk? And a lot of the risk factors for post-extubation dysphagia and aspiration are really not modifiable. There are things like age or comorbid status or length of intubation, but endotracheal tube size may be one of those things that actually is modifiable. So that was one of our kind of impetuses for looking at this. And we had some preliminary data from a previous study that suggested that larger ETTs may, in fact, be associated with greater risk of aspiration, but the sample size was smaller, and it wasn't adjusted for other covariates. So we were able to do that with this much larger study. And the way we were able to kind of assess this in this larger study, and with respect to your question about the technology used, is we used this FEES protocol. So it's a laryngoscopy. So you use a flexural laryngoscope, but there's a protocol called the fiber optic endoscopic evaluation of swallowing, or at this point probably flexible endoscopic evaluation of swallowing, since most people don't use fibroscopes anymore. And it's a protocol to assess the physiologic aspects of swallowing, but also whether or not it's safe by providing different boluses, so thin liquids, ice, thick liquids, to see how the patient is managing it in terms of efficiency, and also whether or not they're potentially aspirating it or their aspiration risks. So that's kind of the safety piece of it. We effectively screened patients who didn't have any pre-existing dysphagia and who weren't being treated for something that could have caused a dysphagia, like a stroke, who were admitted to ICU, who had a diagnosis of acute respiratory failure. And anyone who kind of met that criterion, we had a number of other criterion, but anyone we would do a FEES exam on to see if they were indeed aspirating. And then we effectively correlated it with what endotracheal tube size that they had received upon admission.
And just to interrupt briefly, so it looks like you guys did the FEAST study within 72 hours of extubation. Is that correct?
Yeah, exactly. So we wanted to select a time that was realistic in terms of when we could actually have speech pathology go and see the patient, but not too far out so that they would be potentially moved out to acute or even sent home.
Mm-hmm. And was this the one-time study, or did you look at each patient at several time points?
Yeah, this particular study was a one-time evaluation. We would love to do serial fees to see how aspiration and how swallowing changes over time. That's something that has not been looked at to my knowledge, but that would be pretty fascinating to kind of see the progression of the issue.
Oh, yes, I think that would be really fascinating. And how many patients did you guys wind up studying? And I believe this was a multi-centered collaboration, right?
It was. So we have this fantastic kind of consortium between Boston Medical / Boston University, University of Colorado, Denver, Yale, and Stanford. And so this is part of an R21, and we enrolled 200. Well, we enrolled more than 210, but 210 were the number of people we enrolled in this particular study or in this particular paper. I think we enrolled a total
That's
of about 240-ish.
that's a really nice study. Good job.
Thank you.
So now that you've educated us on the study methods, if you could share with us your findings, that would be really great.
Sure. So the kind of the quick finding was that patients who had an 8.0 endotracheal tube or larger um, had about twice the odds of experiencing a post-extubation dysphagia as those patients who had been intubated with a 7.5 or smaller. Of note, the majority of our sample had either a 7.0, a 7.5, or an 8.0. There were just a few people who were above or below that. So that was really it. And so that was our primary finding, and that was adjusted for a number of other covariates. So, one might initially say, okay, maybe someone with a larger ETT, maybe they were given the larger ETT because maybe they were more comorbid and they were worried they were going to be intubated for longer or may need, pulmonary suction or bronchs. Um, so we adjusted this for age and gender and a whole number of other comorbidities, CCI, and after adjusting for all of it, there was still a significant difference. Again, the odds ratio was at 2.17. So a significant difference in aspiration.
Gintas, just to interrupt,
Sure.
if you could tell us what CCI stands for.
Oh, Charleston Comorbidity Index, and we also use the Apache 2, which I always forget that one.
Oh, that's okay. Yeah, I think
Okay.
yeah, people can figure the Apache, but they both are ways for you guys to analyze whether somebody's medical complexity was associated with the prevalence or the incidence of dysphagia.
Yeah, and whether or not they were correlated with the larger ET size, exactly.
Yeah. What about somebody's like physical attributes like uh, BMI, height, weight? Did any of those correlate?
Yeah, so we did look at BMI, and there actually was no correlation between BMI and ET size or aspiration, interestingly.
Uh-huh. But you did not look at height or weight. specific?
Yeah, no, not as not as a independent predictor.
Okay, all right. Well, that odds ratio is pretty significant, like you said. So, did your group come up with any conclusions about this?
Yeah, I mean, tentatively, I don't I hesitate to be overly authoritative in conclusions, but this certainly suggests that a larger ETT size is associated with a greater risk of aspiration. Um, the underlying mechanisms behind that are pretty, are I should say, elusive. Um, we don't really fully understand any of it, and it's quite fascinating. We can certainly throw out a few hypotheses, um, but really the takeaway is if you don't think the patient is going to be a patient who will be intubated for a very long time or need a lot of you know um, a lot of bronch work, then if you can choose between a 7.5 and an 8.0, go with the 7.5. Um, but of course, you need to balance proper patient care with um, potential adverse outcomes associated with a larger ETT.
Well, I would love to hear your hypothesis, but I wanted to ask you one quick question.
Sure.
Your list of collaborators did include, well, obviously, your home department of otolaryngology, but also a number of pulmonary physicians who undoubtedly had their own reaction to the tube size. Things like bronchoscopy and bronchoalveolar lavage in the ICU. Those are things that are done quite often in
Yep.
this population. So when your collaborators saw this conclusion, I'm just interested. What did they have to say about it?
Sure. So, I have to admit, Mark Moss, Dr. Moss, is the senior last author on this paper. He's the PI of the R21 for the whole project. Um, and I know we had talked about this extensively, and he said, this is a really interesting and great finding. And he had kind of given this anecdote with, they were intubating someone and someone handed him an 8.0 and he said, yeah, I would like the 7.5. So, I think this really does have some significant clinical implications when feasible. And talking to this with some colleagues also, and at least in otolaryngology at Boston Medical, and as I'm sure you know, otolaryngology is involved in a lot of kind of like the emergency airway response projects, and a couple of them said, that just makes sense, and from now on, I'm going with a 7.5 if I can. Um, so I think there are. I don't want to speak for all clinicians across all fields, but um, I think the general idea of if you shove something that's much larger into someone's trachea, then chances of an adverse, kind of reaction to that of some sort is more likely than a small one. So if you can get away with a smaller tube, then why not do it?
I think having data to support that is important, and it sounds
Yeah.
like you definitely convinced your collaborators. You had mentioned that you could think of a couple of hypotheses for this. Please do share with us.
Oh, sure. It's I mean, the raw numbers are pretty interesting in terms of the difference in aspiration rates. I think in general for those with 7.5 or lower, I think a little less than a quarter actually exhibited any aspiration, whereas those with 8.0 or higher had something about a 42% rate of aspiration. So the raw number difference is huge. But the interesting thing is that so there are two, I guess, I don't know if you can call it types of aspiration, but two ways you can classify it. One being silent aspiration, one being non-silent. So, um, silent aspiration is something goes into past the cords into the trachea, and the patient never responds. Um, and so, whereas non-silent aspiration, the patient will either elicit a slight cough or a swallow, usually if the bolus is felt in the laryngeal vestibule, so on or around the arytenoids and epiglottis or on top of the cords, or if the bolus passes beyond the cords, then it should elicit a cough. And interestingly, the rate of both silent and non-silent aspiration increased proportionally. So there's somewhere in there's likely an impact on sensation, both supraglottic and subglottic, which, as I'm sure you know, is innervated kind of two different nerves: the anterior branch of the superior laryngeal nerve and the recurrent laryngeal nerve. And So the question is, what is it about the ETT size that is impacting that sensation? Um, and then the other question is, what is it doing in terms of the physiology of the swallow? Um, and these are all fascinating questions that we don't fully understand.
How did you evaluate the nerve dysfunction during this study, if you did, and what are the different ways that people could do that?
Sure. So I don't know of a practical way to test subglottic sensation other than the fact that if a person doesn't respond to a bolus on your tracheal mucosa, then that should be a clear indication that something's wrong with your recurrent laryngeal nerve. But for supraglottic sensation, a common test for that is to just carefully and quickly take the tip of your endoscope and just tap the arytenoid. And the arytenoid, well, it should move, or the cords should actually quickly close. So that's your laryngeal adductor reflex. Sorry, your LAR. And so if you tap them a couple of times on the arytenoids and you don't see the LAR, then in theory that should suggest that their supraglottic sensation really isn't that great. If I mean, we practice endoscopy all the time on ourselves, just for fun and for research purposes. And I can tell you, if someone taps my arytenoids with a scope, I will most definitely feel it. So how sensitive of a measure that is, that's up for argument. But someone with normal sensation will certainly feel it.
I think that's a really fascinating to think about, that the presence of a foreign body over time somehow causes our brain to really essentially rewire that part and to kind of maybe be comfortable with it. I mean, I don't know. I'm just sort of guessing. But the next question I have for you is: do any of us, and by us I mean you, do any of you know the duration of this adjustment in sensations or this dysfunction?
Yeah, that's a great question, and the quick answer is no, and I'm sure it's person specific. Probably a function of a lot of different things, whether it's duration of intubation or just other comorbidities. But there was a paper published, I think, just last year by Marvin and colleagues that showed that aspiration rates decreased in the first 24 hours after extubation. And that was amongst a heterogeneous group of patients and not just ARF patients. But I would speculate that some of that improvement may have been a function of positive changes in sensation. Because if you can sense the bolus, you should actually, the first thing, if you have good supraglottic sensation, if you sense the bolus, in the laryngeal vestibule, then you should actually elicit a swallow. Um, and then this probably is also a function of general increased strength and general kind of alert oriented nature. That only went to 24 hours. I'm not aware of any research that's actually looked at this beyond that, and so that I think would be a really fascinating paper or a research study to do.
Yeah, I definitely agree with that. Well, I suppose once we can figure out how long this dysfunction is or whether it's permanent, then we can think about how to help rehabilitate these patients. And I know that this is definitely one of the topics that you are interested in and are looking at as well. Do you have any um, recommendations about how to uh, rehab these patients or how to design a rehab regimen for them once they
That's,
have dysphagia?
yeah, that's a great question. I think the first question is to be able to understand the the mechanisms, kind of etiology of the dysphagia. So what aspects of the swallow and of sensation are impaired? Is it a timing issue? Is it a generalized weakness issue? Is it a sensation issue? Is it some combination of all of the above? Um, so um, there's there's another paper that I don't think has come out quite yet. It's been accepted out of this group too. So Susan Langmore is the first author in that one. It should be coming out in the Dysphagia Journal soon. We tried to figure out some sort of phenotype because if we can do that, we can then maybe try to target some interventions, some sort of rehabilitation interventions, or maybe just compensatory ones. So maybe asking the patient to eat and drink and swallow in a certain way, or using certain modified diets, or maybe using some sort of strengthening interventions, whether it's generalized strengthening, or whether it's specific to overall the general swallow or hyolaryngeal elevation or tongue strength. Um, so I think there's definitely a role there for rehab, even in the hospital setting. But the first thing we need to do is identify and understand kind of the biomechanics of this dysfunction.
Mm-hmm. Okay. And then once you understand that, then create a more specific plan. Is that what you're saying?
Exactly.
Okay.
Yep. And I think that's kind of phase two of all of this. Is now that we have a preliminary understanding of kind of what's going on, could we better understand it? Is it, what are the key drivers of aspiration and of dysphagia in general, which includes aspiration?
Right. Yeah, I think it's such a big topic and so important to patients and their families.
Yeah,
I personally hear a lot about how important it is to somebody's like almost self worth to be able to
absolutely.
eat and
Yeah.
swallow. So
Absolutely.
yeah,
Exactly. I mean, eating and drinking is probably one of my favorite things to do. I mean, I love food and I love celebrating, and if that was taken away from me, I would be in a bad place mentally. I'll tell
right.
you.
So that's a big deal.
Um,
Um,
absolutely.
so the biggest finding of your paper is that the endotracheal tube size matters. And what I wanted to make sure I asked for all of the listeners out there who are undoubtedly thinking the same thing is, for now, do you have any advice about how to determine what a good endotracheal tube size is? You and I were speaking about this, preliminarily, but is it going to be something like somebody's gender? Is it their height? Is it their body type? Any any pearls that you can give us now, or is it something that we're going to have to look forward to down the road?
Sure. My understanding is that oftentimes ETT sizes kind of guesstimated based on gender and height. Male larger, you get an 8.0; female smaller, you get a 7.75. I personally don't have any pearls about this. I don't know if there's any good data to support any of this. And I mean, interestingly, talking about laryngeal size could certainly vary by gender, but also in height, but also within gender and height. I mean, you can have a 4'5" woman, you can have a 6'2" woman. Same for men. Um, and so, kind of a question that came up in our group is it really gender and height, or should we be worrying about maybe the ratio between the external diameter of the ETT as compared to the diameter of the glottic space or the trachea? Um, and perhaps it's that ratio that actually matters more than just the ETT size. Certainly, there will be some correlation between person size in general, but yeah, this is a really interesting question. I think one that remains unanswered, but ripe for exploration.
Right. Well, that leads me to my concluding question for you, which is, what is next for your group in terms of this topic of research?
Sure. Yeah. Well, we're certainly moving forward with a few big questions. I think one is, can we identify kind of like what is it about the ETT size um, that that results in this association between larger ETT size and aspiration risk. So we're definitely going to be looking more into that. We're very interested in understanding the kind of the biomechanics of the swallow dysfunction, trying to see if we can come up with kind of like certain classes of dysphagia, perhaps, or um, uh, certain concrete algorithms for what defines the problem, so we can try to target that. And just to continue our work on trying to develop optimal algorithms to predict aspiration, because not everybody has fees available. So kind of another paper that was just published in Chest by Mark Moss from our group delineates kind of this clinical predictive rule algorithm we designed to try to predict who is at greatest risk of aspiration and who isn't, so that they can be appropriately referred to speech. So I think those three things are kind of at the top of our list. To better understand the role of ETT size, to better understand the etiology of the dysphagia, and to come up with ways um, to better identify those at greatest risk of aspiration.
Right. Well, it sounds like our knowledge and our ability to clinically adjust in this area is changing rapidly right now, thanks really to your group. So thank you for that. And I think there's a lot more that needs to come out to help us figure out these outstanding questions, like how to select for the best endotracheal tube size and the time course of the dysfunction caused by the decreased sensations. So I think I for one will be keeping my eyes open for those articles. In the meantime, thank you so much for taking the time to share with us your thoughts on this and your findings.
Great.
Well,
thank you very much.
Oh, yes. This concludes another edition of the iCritical Care podcast. And for the iCritical Care podcast division, I am Dr. Ludwig Lin. Take care.
Ludwig H. Lin, M.D., is an intensivist and anesthesiologist at Alta Bates Summit Medical Center in the Bay Area in Northern California, and is a consulting professor at Stanford University, where he teaches a seminar on the psychosocial and economic ramifications of critical illness. Dr. Lin did his medical training, anesthesia residency, and critical care medicine fellowship at the University of California, San Francisco. He has served as faculty at both Stanford University as well as the University of California, San Francisco, where he was a professor and the medical director of critical care at San Francisco General Hospital. He has interests in patient-family communication as well as education. Being an SCCM podcast host reminds Dr. Lin of his undergraduate days as a news broadcaster for his college radio station, KZSU. Join or renew your membership with SCCM, the only multi-professional society dedicated exclusively to the advancement of critical care. Contact a customer service representative at 847-827-6888 or visit sccm.org/membership for more information. The iCritical Care podcast is the copyrighted material of the Society of Critical Care Medicine, and all rights are reserved. Statements of fact and opinion expressed in this podcast are those of authors and participants and do not imply an opinion or endorsement on the part of the Society of Critical Care Medicine, its officers, volunteers, or members, or that of the podcast commercial supporter.